We want to get started. Okay. All right. Well, we are on the air, so we'll call the meeting, June 26th meeting of the Board of Health to order. We'll start off with the roll call. If you just want to go around and just mention your name.
Charlie Duranona.
Good.
Monica Blankowski-May.
Josh Kearns, County Commissioner.
Health Officer.
Brian Gillespie, Health Officer.
Alicia Thompson, Administrative Officer.
Very good. Mike Cathcart, Cities and Towns Rep, and filling in as Chair for the moment.
Patricia Keenholz.
Michelle Fossum, Legal Counsel.
Okay.
And Mary Cuny is online.
Oh, there we go. Okay, very good. And I believe Commissioner Waldriff will be here at some point, so she'll take over when she does. For now, we will jump into citizen input, and we do have one individual signed up, and I have that name here. Is it, let's say this wrong, Darren?
No, Devin.
Devin, okay. Devin Bell? All right, go ahead.
Okay. Hello, everyone. My name is Devin Bell. I'm the Health Equity Manager here at SRHD, and I'm speaking to you today on my personal time. I would like to share 3 points of feedback about the proposed edits to the Health Equity Resolution. First, the definition within point 1 of the resolution has the definition of health equity that does not currently match what is used within the health district. This would actually be the 3rd definition of health equity that would be used, and I believe would result in confusion around this work. I recommend revising the definition to match what the strategic plan or the health equity definitions document contain and ensure it aligns with sources outside of SRHD. Second, the proposed resolution talks about ensuring equal access. Equal access is not enough and will not move the needle at all when we're talking about advancing equity. Equal implies that we all get the exact same thing. For example, I am wearing heels. I can give each of you the same exact heels, and that would be providing equal access to shoes. However, if we're not the same size, or if you're not comfortable wearing heels, this would not be enough. Instead, I would need to take into account your shoe size and personal preference for footwear. This would be an equity approach. That is what is needed in this resolution. Equity, not equality. The language we use is important and holds power. Third, under point 5, there's an edit regarding staff training. It adds that trainings will be voluntary. How can there be understanding and clarity about health equity within SRHD if there isn't consistent training across the organization? This item will lead to more misunderstanding, which Resolution 2502 aims to avoid. Health equity is also at the center of public health, as well as a core value at SRHD, and those working within the field need to have clear understanding of what that means and how it looks in action. Consistent training across the organization is the best way to do that. I appreciate the opportunity to share my feedback with you all today, and I'll hope you keep it under advisement when taking action on this resolution. And better yet, as my dad likes to say, if it ain't broke, don't fix it. Thank you.
All right, thank you so very much. And then I know we had talked about in our exec session moving up our action items. So do we want to move to our consent agenda then? Because Commissioner Kearns and I both have to leave by 1:30. So, all right, very good. Let's move to our consent agenda. Can I get a motion to adopt the consent agenda?
I'll move to adopt item number 5, the consent agenda, A through D.
Second.
Second.
Okay, motion and second. Any discussion? Hearing none. All in favor of the motion, say aye.
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 Any opposed? Okay. All right, action items. So moving on to number 6, Resolution 25-02.
I think I get to talk about this one for you all. Before you today for your consideration is Resolution 2502 regarding health equity, which is a core value of the health district. Lately, there's been much reporting of issues related to diversity, equity, and inclusion policies across the U.S. And we wanted to be sure that the prior resolution on health equity was defined appropriately to avoid any confusion on what we were doing. So the resolution amends and clarifies Resolution 2007. In summary, it defines health equity as the fair and just distribution of health resources and outcomes so that all people have equal opportunity to achieve their optimal health potential, regardless of their social, economic, or demographic status. That SRHD will continue to use its internal infrastructure to advance health equity. SRHD will continue to develop strategic partnerships to improve access to resources and outcomes. SRHD will encourage and foster community partnerships to advance access to health resources through education. SRHD will provide voluntary educational opportunities regarding disparities in access to health care in a manner that's consistent with federal and state discrimination laws. And SRHD will continue its policy of recruiting and hiring qualified candidates based on merit, qualification, and competency. It's not a change in policy, but a clarification of what SRHD's health equity policy means. Happy to answer any questions if anybody has any.
Any questions from anybody? Okay.
I have a question. So I'm just trying to reconcile what Devin was saying about what is equal. And is she recommending that changes are put in here, or I guess she left already, but
And I'm not sure exactly if she's recommending specific changes. First I've heard of it is right now with you, so.
as well as me. And so I feel that the amended resolution is quite appropriate, and it still includes it includes what we need to do to have health equity as one of our core values, and as part of just public 10 essential services of public health. As core is equity. And so I believe it will help us with the federal executive orders.
I would just encourage her later, if she has some specific issues with what's in here after it's adopted, if it's adopted, to come back later and let us know.
Yeah, I have just a question also related to Devin's remarks. Under number 5, one of the things that I thought made a good point was the voluntary educational opportunities, and suggesting that if it's voluntary, is the agency really promoting consistent, clear education? Would it be reasonable and minimally invasive to just pull out the word voluntary and just say, by providing educational opportunities to staff?
I agree with Monica. I think that with a lot of professions, there are CEUs, continuing education, that are not voluntary. I believe that public health, they should keep up with the educational piece of things. So I don't know if maybe just taking out that word and just keeping it as providing educational opportunities and taking out voluntary. I don't know, just maybe.
That term was intentionally included to make sure that there was no claim that anyone at SRHD or elsewhere was being required to take certain types of classes that they may find offensive or not agree with. And so that's why that word was put in with respect to issues related to disparities.
Any other comments? About either the change or, yeah.
Sorry, Councilman Cathcart, but I also want to let everyone know that what Michelle just shared with you isn't coming from us. It is coming from the federal government. And so I know that we're the state of Washington. But we just felt like it was important to put that word in there so that would reduce our risk. I certainly hope that there's very few people that would not voluntarily go to our classes on health equity, especially since it is a core value and because it is at the center of the 10 essential services.
Okay. Well, I will just say that I think the resolution does a really good job of trying to comply with federal requirements while not conflicting with state prohibitions. And I think that was the goal of the changes, is to find that right balance. And I think this accomplishes that. So if there are not any other further comments or motions, then we can consider number 6, if there is a motion to adopt.
I will move that we approve action item number 6A, which is a resolution 25-02, amendment and clarification of resolution number 20-07 regarding Spokane Regional Health District's health equity resolution, health equity response.
Okay, we have a motion. Is there a second? Can I, as the chair, second?
I will second the motion.
Thanks, Commissioner. Okay, any further discussion on the adoption of 6A? Seeing none, all in favor, say aye.
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 Any opposed? Abstaining? All right, motion carries. And then 6B, treatment services proposal.
Good afternoon. So we wanted to talk about treatment services expansion implementation proposal. And to start, this was the timeline that we wanted to show that we would be able to offer. And as it sits, this would be in alignment with, by the end of this month, we would have, and we currently have position descriptions that would be built and ready for recruitment. Next month, we would begin with the recruitment process and then the hiring and onboarding throughout August. September would be the working on the operational workflows, policy and procedures, tasks, and updates. And then throughout October, and September and October would be communications to community partners with a potential go live in November. Now, again, this is with the idea that there are no significant hiccups or major bumps in the road, but this is for the below listed positions that we've previously discussed for the expansion opportunity. Which one? There. So additionally, with that, not only for the timeline for this process, the expanded hours would be that currently we operate from 5 a.m. till 2 p.m. And this would expand us from 5 a.m. to 6 p.m. with our dispensing hours beginning at 5:15 to 5:30 p.m. And Saturday from 7 to 3 for staff, and dispensing would then be from 7:15 to 2:30 on Saturdays. Now, go ahead. Now, to elaborate a little bit further, currently our dosing hours end at 11:45, and that is to give our dispensing nurses the opportunity to clean up and do what they need to for reports. However, at 11:45, our doors close, but that means that any individuals that come inside by 11:45 are then able to receive their medication, provide their urinalysis, and oftentimes we're done by noon. However, depending on day of the week, time of month, if there's holidays, additional take-homes, things of that nature, it can go well beyond 12 o'clock. After that time is when our nursing staff have the opportunity to clean up their stations, run reports, count the inventory, make sure all the numbers match up, and get all of their final documentation done. So that's why there's the additional time frame at the end of the day for dispensing for the nurses to get all of those pieces taken care of. And that would be done on Saturdays as well. So dispensing would close at 2:30 and staff would be done by 3 o'clock on Saturdays.
I'm sorry, did you say by 3 o'clock?
Staff would be, on Saturdays, staff would be done by
So how late would the dispensing go on Saturday?
2:30.
Till 2:30. So they can get their station cleaned and run their reports in a half hour on
Yeah.
Saturdays?
Correct, because the volume of patients and the volume of work would not be as much on a Saturday as it would be throughout the rest of the week.
Okay. How long does it typically take to clean a station and run the reports and do the inventory?
It can vary. To clean a station, it can be anywhere from 10 to 20 minutes. Depends on if they need to do calibrations. Running the reports, they have to match numbers up. They have to run the counts on a variety of, they have the cherry methadone, they have clear, they have the Suboxone. And then they have to have 2 different nurses that run those reports to verify the counts. So again, it just depends on, sometimes the clear methadone is not having to be poured because maybe an individual that's taking that medication doesn't come in on that day.
Okay.
So there's some variances that take place. And on Saturdays, again, that volume is not there.
Okay. I mean, I guess it's just, it seems to be a big get on a Saturday, they can get it done in a half hour, but during the week, it could be 2.5 hours to get it done. Well, you said if you're closing, your last person, maybe.
So the nurses start
noon.
at 5 a.m.
Okay.
and they're done. They leave by 1:30.
They leave by 1:30. Okay. So
Dosing ends
But so an hour and a half, it could take them during the week then.
potentially, but there's also other things that they're doing besides just cleaning their stations and running the reports.
Okay.
They've got verification for the jail. They've got to check on the jail doses throughout. So there's a multitude of various pieces that they're doing as well throughout the week that they wouldn't necessarily have to do on the
Who's
Saturdays.
there until 2:30 then?
The counselors, the AAs, the other staff throughout the building, the management, security,
Okay. Okay.
all the other staff besides the RNs,
Okay.
ARNPs, medical assistants.
Okay. All right. Thank you.
Other questions, comments? I will just say, as I've learned a little bit more, I'm very challenged because there's been all this conversation that treatment services is open until 2, and only very recently did it come to my attention anyway that we actually stopped before even lunchtime with providing the dosing. And it seems like lunch would be the most obvious kind of thing we could do tomorrow, is provide that extra hour when folks could actually get to treatment services. And so it just feels a little misleading that we're going to be opening, significantly more, just because of the way it's kind of been presented on that. And then also understanding that we hit 1,200 individuals in treatment services just a couple of years ago with the number of staff that we have now. And so I'm really challenged, and I haven't seen a staffing plan or anything yet to understand exactly, how the new staff would be assigned, what the workload would be, trying to understand how that compares to the workload when we hit 1,200 before, and just what's necessitating such a huge expansion to meet kind of that same need that we've already addressed previously.
The biggest challenge is schedules. So we can't, like a dosing nurse who's scheduled from 5 to 1:30, and they need to finish all of their paperwork before they leave. And so right now we have 7 windows open for dosing, and our throughput, Adam, our throughput is usually somewhere around 300 an hour, 294. Come up here. come up here, please.
I don't know per hour. It's been a while since I ran those numbers, but in a day, for over the hours from 5:15 until 11:45, we'll have dispensed to, on average, about 400 people per day. But if there's a holiday, then it's going to greatly expand the number of like carries. If there's any special things going on, I mean, and for those 400 people, you could have a lot of volume going out for those people.
But how does it compare I think 22 is the year I was told that we had hit 1,200, and so how are we comparing then to that?
In respect to dispensing?
Yeah.
So the barriers are that we had, especially when we were here, even at the new location, we had a significant wait time. Patients were sitting in the lobby in the rotunda here for an exhaustive amount of time. And because we just didn't have the capacity, we didn't have the staffing to meet the patient needs. We had the patients and they were here. We met their need as best as we could and they were here, but I think that's also part of what contributed to our decrease in numbers was we weren't able to get them through in a timely manner. Some patients at times were sitting here in our rotunda for upwards of an hour and a half to 2 hours because we just weren't able to get them in and out in a timely fashion.
Well, and that's where I feel like the simplest thing we could do right away is just expand to cover lunchtime and see what that does, because there's probably a lot of folks that just don't have availability, but lunchtime might work for them, and we just don't offer that. And so that seems like a simple tweak that we could do pretty quickly.
Again, that goes back to schedules. And so what I'm hearing you say is lighten the morning schedule and
I'm not
increase.
saying that. What I'm trying to emphasize is I haven't seen a staffing plan, so I can't even wrap my head around exactly how. But what I am saying is just strategically, if we think about covering lunchtime, that alone, that 1 extra hour a day, give or take, probably would net a big increase in folks seeking treatment services. That's my hypothesis.
I'm kind of a little confused.
Please.
What's the difference between adding the hour of lunch versus just at the end of the day at 6 o'clock? Because there's a lot of people that would work or whatever the case may be that they can't get here during lunch. Like I have a hard time getting in here at lunch when I work on base.
Obviously you're not going to drive out from base.
Well, yeah.
But no, I mean, the point is we've seen a precipitous decline, and whatever the reason behind it, it has reduced significantly. And we're talking about a massive expansion. No guarantees that we will have the populace to cover those costs. And so are there some reasonable intermediate steps that we might take to see if that will improve the situation before we take this big step? That's what I'm saying.
I got you. Do we know if we have more people that want to get here during lunchtime versus after work at 5? Have you seen like people trying to get here in time and closing the doors at lunchtime versus, at the end of the day?
Well, that's part of the dashboard that we show you, the number of people that are turned away from assessments. I don't know if we have a number of turned away because they came late for dosing. I don't know.
So historically, we do have individuals that show up at the end of dispensing regardless of what our hours are. And it tends to be the same individuals regardless of when our closing time was 9 a.m., 11 a.m., 12. We have gone till 1 in the past. We have pulled it back. During COVID, we changed and adjusted based on flow and staffing and workforce. And it consistently remains the same group of individuals, regardless of whether or not that time is 9, 11, 1, 12. It's always the same population.
Other comments, questions?
Oh. And we did prepare a draft schedule, but we were concerned that if we showed a draft schedule here for the new hires, that it could be perceived as that's what's going to happen by staff and by others. And so if that's what you want to see, a proposed schedule of the new positions, we have that. We can share it with you.
That'd be great.
I'm all in support of anything that, I mean, we have a really big problem in this community and in the country with opioid issues, and anything that we can do to help 100%. But I'm a little confused in where you're telling me right now the dispensing ends at 11:45, but your expansion is saying that you guys want to go from 5 a.m. to 6 p.m. and dispensing until 5:30 p.m.
They're going to work
That
at
is a
becoming more.
significant jump. Why can't we just try to expand from 11:45 to maybe 1 or 2 in the afternoon versus all the way until 6 p.m.?
Again, that was staffing hours.
Okay.
And SRHD does not like to hire part-time staff. We like to have full-time staff on board.
Okay.
And so that was the logic behind that, because we would have to hire part-time to make that, even if it was to put it through lunch.
Because of the scheduling requirements, we wouldn't want to shift away from beginning dispensing at 5:15, because one of treatment services missions is to help the people get back to work, and getting them dosed before they have to go to work is very important.
A question. So I'm just doing my little rough calculations, but guessing that you're probably serving about 10 people per hour per window. Does that sound around accurate if you had 400 people a day and seven windows?
So not all 7 windows are running from 5:15 till 11:45.
Okay,
based
that
on
was going to be my next
lunches
question.
and
So
breaks and
if you have 7
vacations
windows,
and
how often are the full 7 windows operational, or are you rotating those? And then how many windows would you plan to have open in the expanded version?
So they rotate their breaks and their lunch breaks. So when everyone starts at 5 o'clock, everyone's on the floor. Well, and then they get ready for dosing at 5:15. And so everyone's on the floor. Then some of the staff goes out on their break. They get a 15-minute break, and then they come back and the other staff go out for their 15-minute break, and the same thing for lunch. They rotate through.
So the windows are closed during the times that they take their breaks?
Yes.
Yeah, okay, so,
And we currently have 6 of the windows that are operational because the 7th one is being recruited for currently.
okay. So it sort of seems like we would have the potential to take in considerably more people than the 54 that we've turned away so far in the first quarter. Is that accurate? And so what is the number that you've projected for how many people you think you're going to serve? Figuring that you wouldn't be turning away 54, and how many are you going to be adding? Just speculating.
We didn't come today prepared to go over the full expansion proposal again, but that is included in the expansion proposal, and we provided that last month. And so I don't want to speak to that without, having, I think it's 1250 but that's my recollection from a month ago.
Thank you.
Yeah, so what I'm hearing is that the expansion, part of the structure of the expansion has to do with the model of care that requires, this whole different specialties, kind of a multidisciplinary approach. Dosing is one piece of that, but that even staffing, how we provide this model of care is limited a little bit by, we can't really do like part-time people or, the structures that would be sort of, well, we'll just increase the number of nurses doing dosing, and we'll keep everything else the same, because it's part of a whole comprehensive model of care. Is that
Correct.
is that what makes it a little hard to just sort of tweak and say, okay, you know, we'll stagger, it sounds like you've, over the course of your time, you've maybe experimented with various staffing, who's on at 5:15. You don't need everybody at 5:15. Maybe you just need one person at 5:15, and then you stagger. All those things, I would imagine, you guys would manage within that model of care that you proposed. So to see more people, we need to resource more according to the model of care. Is that
Correct.
like, I have no interest, I don't have any specialized knowledge to say, you know, you have much more experience to say, well, why doesn't Mary start at 6 a.m. and, you know, Julie start at, I mean, that's out of my, out of my realm.
It's 1150, just to answer the question before, for the number that's estimated in here is 1150 per 11 and a half hour day. To me, it seems like if you're doing 400 a day now, that's 3 times the amount of people that you're currently doing, but you're not really tripling the amount of time that you're going to spend, are you? So it seems a little lofty to be projecting that we're going to triple the amount of patients that we're serving when we're not quite sure if right now we've turned away 54 people in a whole quarter. So
And I think the thing is that it's not tripling the amount of people we're serving. It's the number that we could get through in that day. And again, some of those numbers could be that one individual is coming through 6 days a week, and another individual is only coming through once every 2 weeks. So those numbers could be that, you know, maybe our census is actually higher than that 1150. So it just could be that how many people are coming, and those courtesy dosers can also account for that. So we've got people coming through that are from other clinics across the state, and they're not part of our internal census that are specific to SRHD treatment services.
the census says 1,200 to 1,350, and then the estimate says 1,150 per day. So it's only really 50 to 100 or to 200 different between the census and the estimate. So it still seems like a kind of a big jump. I'm in favor of, you know, trying to make sure that we can reach capacity with the need. I just am trying to figure out whether the calculations that you're proposing are more than what we need. And I think that's what some of the other people are kind of alluding to too.
Commissioner Kurtz?
You know, I still have the same concerns I brought up last week. I mean, I want us to serve as many people that are willing to get this service. This is extremely important. But I mean, expanding that much as far as the hours go, how do we know the patients are going to come? I mean, this is kind of a, if you build it, they will come kind of moment here. How do we know that the folks are going to show up? I mean, certainly there are people that need this service. All you have to do is turn on the news or read the paper. We know there are people in this community that need this service. But I mean, at the same time, for us to invest this large of amount of dollars on really just the thought that if we expand the hours, something's going to click and folks are going to come in and now get these services just because the hours are different. I mean, how are we so certain of that? Because at the same time, there are other players in the game of treatment services. There are private organizations. There are other entities out there. Are they expanding their hours?
Not that I know of.
And if they're a private for-profit business, if the dollars were there, if the clientele was there that they could get reimbursed for, don't you think they would have already expanded?
I can't speak for the private OTPs. I just know that we were trying to find an innovative solution
Yeah. Oh, no,
that would help individuals to have greater access
Yeah.
to our opioid treatment program.
Yeah.
And so, just like Misty has already said, she's trialed other schedules and found that, they didn't work. And so, again, this is a trial. And when I talk about these dollars, we're asking that they be put in an assigned reserve. And then finance will create a budget account code, a BAC, for the staff and the expenses for expansion. And so it's like, that's what will be charged on this 850,000. And if you have questions about that, I'll bring Kim up here, because we work together to figure out how can we keep this amount, which was the surplus from 2024, how can we keep it so that it is totally designated to only expansion expenses? And the reality is that we don't have a crystal ball. We just know that Spokane has a big problem, and we know nobody else has tried this. And so we're like, we would like to try it and see. We have a suspicion that there's a lot of people that would come for services in those hours, the afternoon hours.
So if you hire up additional folks to do the dispensing, you hire up additional nurses, counselors, for that holistic approach, what if the clientele's not there and this doesn't end up being successful or having the sustainable amount of clients coming in?
Mm-hmm.
What do you do with those individuals that you just hired up? If we need to scale the hours back because we don't have the clientele, we don't have the reimbursement dollars coming in to pay for this.
Mm-hmm.
I mean, do we just lay those people off? And just, it was a trial, it didn't work? Thank you for your service?
Well, if you notice, this looks like a lot of positions, but this is the multidisciplinary staffing that you need to have to provide all the services that treatment services provides during the hours we're open. And so our primary objective with these positions is to make sure that any walk-ins are seen. And so that will be the priority of these positions. And so if it doesn't work and we don't have people coming in after we've done all the blitz of the community and Facebook and all of the electronic media outlets, and then we know we need to scale it back. And with this looks big, but this is not. It's like we have 2 counselor positions open right now. And so within the opioid treatment system world, it's very common to have like a 37% to 45% turnover among staff. That's just part of the nature of the business, because it's hard work. It's hard work. And I'm just thankful that we have a whole lot of people over there who are very dedicated and have stayed with us for a long time. But we hire trainees and get them trained up, and then they leave for other jobs. And so I actually don't really have a concern about if we have to decide to scale it back, that we will be able to integrate these positions back into whatever hours we decide we need to scale it back. For example, if we see like no one shows up between 4:30 and 6, then we scale it back to 4:30. But we're going to have to try this for a full year, because it's going to take a full year for the community to realize that, oh, our hours are longer. And so we're not talking 2 months. You know, we need to commit to expanding the hours for at least a full year and then reassess.
Sorry to come in late to the conversation, but what I'm hearing is that because there's a lot of movement in the positions, likely if we would have to scale back and like eliminate a position, there's other positions for people to fall into. That's just the natural course of the work. So that's good. We're using funds and we'll only use what we need, right? From that reserve fund is the proposal as we're starting to hire staff.
Kim, you
So
want-
it takes us a while to even get to that 850,000 number because it will take time to hire, build up the staff, and be ready to, and I'm sorry if I missed it, what are you hoping the estimated date might be to do the expansion hours?
The anticipated go live for all pieces would be by November.
Okay. But on the financial side, it's basically a reserve amount. We'll pull from that to hire the new staff, get them situated. So it may be we don't even hit that 850 for a long time. And then we'll start to see revenue come in from new patients, right, that are seen during those new hours, or patients that might switch their hours, right, around and leave other spaces for other patients at other hours. So there'll be a lot of movement, but the money will just be spent as we go. And we think that will get us to the point where then we have the revenue coming in to cover the costs. Is that right, Kim?
If there's a decision today, we would transfer from our unassigned reserve, whatever amount you determine, into assigned reserve, and that would be in our my monthly report. And then we'd have a special project code for all those expenditures. And then as they spend it out annually, then I would replenish the unassigned by drawing down the assigned, is how that would work.
Great.
Yeah.
Okay. Well,
And-
I think that a year at a minimum is like a reasonable amount of time to try a new schedule. I think that it will take us a while to get to that point, to get fully. And then I know when clinic hours change, I know when I go to clinics, like if they change the hours, it takes a while to remember that and let folks know. And the word of mouth on the street will probably be actually even more effective than like social media.
The community outreach will be.
Anyway, I think you guys have done a really good job on this. And yes, we can't answer everything today, but I think the risk to the agency is pretty low because we have the dollars to invest and we have a plan. And so I think that for the benefit of the whole community, with the county commissioners just got an update from the medical examiner this week. And, you know, while Washington State is starting to see a decline across the state, in Spokane, we're still seeing an incline in opioid-related deaths. So it's definitely a situation where I think the health district can step up and provide some access and leadership. So I support the proposal.
Kim, could you clarify what the net surplus is from 24 and then today? Do you know?
So yes, the 853,918 is the surplus specific to treatment services for 2024. We had approximately 2 million that went into unassigned reserves collectively as an organization. The 2025, I believe that's in Alicia's report coming up, and I think it's about 300,000 surplus for 2025.
To date?
To date, yes.
Okay.
Year
And
to
you're
date.
saying the net surplus from 24 was 850? There was
Yes.
nothing else?
Yes, for
Okay.
that calendar year.
Okay. Okay.
Yeah, and in prior years, we had some surplus in treatment services, but the board made a decision to allow us to allocate those dollars for the relocation. And so we did exhaust them through that method.
And if I could ask, do the commissioners have a sense of if the amount of money that might come from the county will change given budget restraints?
Yes, it's, I think very realistic that the amount that comes from the county will be less than it was for this calendar year.
Okay. So I will just say from my view, I mean, I still have substantial questions. I don't entirely understand how just 3 years ago we were able to achieve service for the exact number, for more than the number that we're saying we're going to treat today and have to add a number of positions for. I think there's some either phasing in or some other alternative ways to maybe approach this to see some expansion, understand the success, limit the risk to the agency. So if it comes to a vote today, I'm not going to support it. I would support a deferral, but that's just kind of where I am at.
Councilman, can I add something?
Sure.
So we were under the impression that both the county and the city had drawn back the opioid settlement funds that they planned to support SRHD with for expansion. And so I haven't heard or seen anything that's still on the table. And so that's why we asked for the 850. If the county and the city are actually going to contribute to this effort, then we would ask for less. We were just trying to make sure that we had enough to do this and maintain it until we started receiving the fees and the revenue from the expansion.
Well, speaking only from the city side, we voted to approve the dollars, and there has been zero communication that we're doing something different with them. So my presumption is it's still moving forward, but communication isn't always the greatest.
I haven't heard a thing other than an article in the newspaper. And I'm sorry, it's an article in the newspaper. I don't know what else to say about that. Yeah, so I don't know.
Oh, yeah.
So if there's a concern by this board that for financial reasons, we may want to pull back on that 850, I think that the commissioners we have the opioid, we do still have opioid settlement dollars. I think that if I remember, Commissioner Cuny was just exploring if we have dollars here, there's a nexus to be spent to expand the services. I'm not speaking for her, but I remember she was saying, well, let's explore what we have here. And then if we need to look at the opioid settlement, we could, there's Commissioner, sorry, Commissioner Cuny. I didn't see that you were up on the Zoom, but I know that we were going to.
That's okay.
We were going to explore that first. So, and then if we had concerns about the financial stability of the health district, and we thought there should be other funds from the county or city contributed, we do have those funding sources. So, we could look at that if we think the 850 is putting us at some sort of financial risk here at the health district. But I haven't heard that so far.
No, because it is a fee-for-service clinic and it generates its own revenues. And it sounds like at the federal level, the Medicaid is safe for individuals enrolled in an opioid treatment program.
But you got to have the individuals to get the fees, and that's part of the question.
And we do navigation. And so when we have someone that comes in and they don't have Medicaid, we help them sign up.
Okay. Is there...
So can I just interject? I'm sorry. So a couple things. So Councilmember Cathcart, to your question that Josh was trying to answer on, is you're talking about not these additional funds from the opioid settlement dollars. You were asking, if I'm not mistaken, I just want to clarify, you were asking about the dollars, our normal annual allocation that we do to our outside agencies, of which the health district is one of those.
Correct.
And Commissioner Kearns did state that, yes, we are looking at all of those and looking at reductions in all of our outside agencies at this point in time. I think to clarify on using the reserves and the county using opioid dollars to supplement is we don't want to supplant dollars. And so I think we were ready to move forward. And then I believe it was, Dr. Thompson, you can correct me if I'm wrong, but then you guys came up with the plan that you could use reserve dollars to do it yourself and not have the need for the city and the county dollars. So I think that's where then I stopped asking questions because you put forward the plan of using these dollars. So I, I mean, I think we can still have those conversations on the settlement dollars if they're needed, but to me, you know, you're showing that you have the ability to use these funds to do that. And so I'm not sure, from the city and county's perspective, if you can show us that you already have the dollars, then there's not the need for the additional dollars unless you can show us why there's the need for the additional dollars. So I think there's two things that are going on the financial side. One is just the normal allocation from the county, which is separate than what this is. And then is there a need for the city and the county to use opioid settlement dollars to provide additional expansion, which is what we were all wanting to make happen, but the health district seemed to be stepping up to say they could do it themselves. So that's my understanding on the financial side of this.
And just to confirm, and can I just tell him to not be joining this link? Jeremy, please get out of this link. Please leave it. Keith, sorry, Keith, it's the wrong link. Thank you. Sorry. Anyway, so there's a nuance to this. What we're asking you to do is to allow us to use the surplus from last year to put in an assigned reserve so that we can charge all expansion costs to that assigned reserve. And so it's like the money is there. It was put into our unassigned reserves last year at the end of the year. 853,000 of the money that was put into the unassigned reserves was from treatment services. And so it's the board's decision whether or not they're going to allow treatment services to use that excess funding for this. And Kim was right. The 2020 and 2021 excess reserves, the board did allow that excess funding to be used for the remodel of 8th Avenue and the move to 8th Avenue. And that's how they were able to cover those costs. And so, are there any questions about that?
Okay, so wait a minute. $850,000. Okay, so you were saying that 853,918 is excess money or
Revenues.
surplus money that your treatment programs did last year.
Yes.
Right? That money is already here and it's surplus.
Yeah.
You're not asking extra money from the county
No.
or the city.
No.
Okay. And at the same time, like Commissioner Wardrow said, you're not going to use this. You're not asking 850 like lump sum. This is
No.
just, and we're going to be getting money back from SIX.
Yes.
Okay.
We'll be generating revenue. Mm-hmm. We just don't know exactly how much.
Hence why we do this for 1 year, and in 1 year, if we don't see.
Exactly.
Okay.
Mm-hmm.
Sorry with the hand motions.
Yeah.
Any other questions, comments?
I just have a comment. I think that we have a big problem in Spokane. We have a big problem nationally. I think the district did a great job coming forward with an approach to addressing this problem. I think the city and the county needs our leadership to prioritize this issue. I think we have the surplus funds earned by the program that shows that it's a good, solid program. We have lots of information that the program is is well received and solid, I think this is a great time to invest to build this program and serve the needs of this county.
Are there any other comments, questions, or motions?
I just have one question. So if in the example of this year where we have 350,000 surplus to this point, right? Is treatment services able to use the surplus that they already have generated for the year to put towards this proposal?
So for the expansion, we will not be charging the expansion for any of our facilities costs, our maintenance costs. So the main treatment services is going to be absorbing those additional costs. So, if we have to open up another office because there's overlap and we don't have another office for a substance use disorder professional, then we would use treatment services dollars to outfit that office with the furniture and the computer and everything that's required for a workspace. And so all we'll be charging for treatment services expansion is for the staffing and that potential software that we talked about, so that can help us to do the scheduling and make sure that our coverage for the whole time is covered. Because our scheduling has been pretty simple up to now. It's everybody's on the same schedule as far as the hours that we're open.
So one more, can you just walk me through the timeline again, just so I know? So you're saying you can be up and running by November of this year, you think? And then the pilot will run then November to November of next, of 2026?
Yes.
And so we will have a decision kind of in November of next year prior to adopting the 27 budget on sort of what the future of this pilot is and whether it was successful or not.
Correct.
Okay. All right. I still have some concerns, but I think there's been a lot of good points here made about, that these are surplus dollars that were raised within treatment services, and it is a pilot that has an end date, which it'll be evaluated, and if it's successful, which I hope it is, we can continue from there. Or if it's not successful, we can look at adjusting, whether that's scaling back the hours or adjusting, or we're doing away with altogether those extended hours. So I'm willing to make a motion if nobody else has anything else to say.
And I'll second that motion.
Well, I gotta make it.
Well, make it, fine, make it. Sorry, Josh.
So, I will move that we approve action item 6B, the approval of the treatment services expansion proposal as presented here today.
I second.
All right. So there's a motion and a second. Is there comments? I'll just say from my perspective, I don't think I can make a motion as the chair, but I would love to see the motion modified to at least suggest that rather than waiting until November for the expansion, that we immediately consider overtime options to expand for lunch hours. I think we should be, if we're truly doing this because of the situation out on the street, then the delay till November is frankly unacceptable. And we should be able to do this right away. And so I would love to see a plan that shows that. I still have substantial financial questions and concerns on the broader plan. If we would do that, I would support it and would be open to the pilot at least. But I'm very concerned that we're not going to see the numbers and the surpluses are going to drop off.
Misty worked closely with our human resources to determine how long would it take to hire and onboard and train those individuals. And so that's really what made the timeline longer. And our staff already has schedules that are approved by the union. And
Well, but again, that, as you pointed out, we can make changes to that. We just have to give a simple notice. And that just requires us to, you know, basically emphasize that these are changes that have to be made. I don't think we should be deferring that because it's a hard conversation to have.
understood.
Can we move forward with the motion that I made and then ask that you do examine if there's any way possible we could expand to those lunch hours prior to November? Is that something that just at our direction, we can task you with really pushing that to do whatever you can to make that happen?
Yes.
Yes. So can I comment?
Yeah, please.
I agree. Thank you. I think we know it's an urgent need in our community, which is why we've been trying to look at this for a while. And I do know we can make changes to schedules with proper notice. And I think if I hear, I mean, people at Treatment Services are dedicated to the community as well. So, I mean, I think we can have those conversations sooner than November as well. But I will approve the motion as it stands, asking for us to look to collectively work together as the health district to make this happen as soon as possible.
Any other comments? Seeing none, we'll move to the vote. All of those in favor of the motion by Commissioner Kern, 6B, say aye.
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 I
Any opposed? Nay. And abstaining? Okay. The motion passes. We will move along and you can take over as chair. I believe Commissioner Kearns and I are both going to have to leave for STA.
Pretty soon here. Okay. Well, thank you. Thank you, council member, for sitting in my absence. My daughter had a little medical thing come up that we had to go take care of right away. So here we are at the health district. She had to drop me off. She's like, oh, this building. So thank you for chairing the meeting for me the first hour there. And we're going into an executive session. So Michelle, can you state the reason for the executive session, please?
Yes, so the board will be in executive session for 15 minutes for potential litigation pursuant to RCW 4230-110-1I. And I would ask that the board members stay, legal counsel, and Dr. Thompson.
Okay, thank you. We will adjourn to executive session and then the meeting will continue. And if there's any extensions, we will announce that to the public.
So this is the agenda for what I'm going to be going over, and we'll try to make it as quick as I can, because I know the time is, we want to make sure Melissa has a lot of time for her community health presentation. Okay, so the Tribal Board of Health member process. There's two sides of this that have to be taken into account. How will SRHD, what processes will SRHD put in place, and then the resolution on the county side. And so what I'm presenting today is the process that SRHD is putting into place for the new Tribal Board of Health members. And so the first thing is who's eligible. And that is one representative for each federally recognized Indian tribe that holds reservation or trust land within a county. And that representative has to be selected by the tribe, and then the tribe notifies the American Indian Health Commission. And the other way to be eligible to have a representative on the Board of Health is for if you are an urban Indian organization recognized by the Indian Health Services and registered as a 501c3 organization in Washington that serves American Indian and Alaska Native people and providing those services within our county. Again, the organization has to select that individual representative and then notify the American Indian Health Commission. And so what is the process on the SRHD side? You identify your representative. You notify the American Indian Health Commission, and then you either call me or email me, and my phone number is there and my email address is there with the representative's name and planned date to join the Board of Health. And I want to make sure that everyone knows that the date to join the Board of Health is going to be dependent on the county's side, the county's process. And so we're hoping that when the county's process is done, that we will already have those names ready to give to, so that we can follow the resolution. Yes, ma'am.
And you're correct. We're setting up the process for updating our resolution that's on file about the process of appointing members to the Board of Health per the new state statute update. So, but it is the process though for American Indian organizations or tribal organizations is to send their representative to the
Yes.
health district. We're working on our end to, integrate that all into the resolution and then talk about how elected officials get appointed in the process too. So,
Yes, because there's a balance that
Yes.
has to be maintained, and that will take, yeah.
but
we'll just
yes,
have to
July
maintain.
27th, the statute becomes effective. So on our end, we're working to get our resolution passed before then.
Okay, great. Thank you, Commissioner Waldron. Okay, and so then you send a letter on letterhead from your tribe or organization with your selected representative's name and their contact information, and you send that to this address. And that's my address here at the health district. Any questions about this? Okay, we'll move on. State and federal updates. So I prepared this before I got the email today, or late the night before, but we did receive notice that a few of the federal notice of awards have been received by DOH. And they're not specifically funding streams that we get, but the movement of hearing that the Washington State Department of Health has received notice of awards is hopeful. So we're hoping that the notice of awards from CDC, which are the main ones that we need to get before, we're supposed to have them, July 1. So we're getting really close. And of course, the DOH cannot send us a contract if they don't have a notice of award. So we're still kind of in a pending place with that. And then we received some very good news from about our foundational public health services funding. It's only being reduced by $150,000. And that is a typo. I learned that the program did start last year, but it only funds a part of 2 positions. And we are getting another new funding stream that we're hoping we'll be able to cobble that together and not have any staffing issues around that. Then the additional 50,000 reduction will be, and I realized at this moment that I didn't finish it because we hadn't made the decision. And what we did was we identified FPHS funding streams that we've had difficulty spending. And so FPHS funds, if you recall, we have reinforcing capacity, where we get to choose how to use those dollars. And then we have 2 categories. We have 2 categories that are, it has to be used in this way. And so what we did was we identified 3 funding streams that had just every year had problems spending down. And we chose to tell WSALFO that those are the 3 programs that we were going to use for our reduction. We are planning to use some reinforcing capacity dollars, like around 25,000, to cover the work that was being done in those programs. And so again, no impact to staff from that cut. Any questions? Yes.
So on the dollars with this contracts where the federal government hasn't entered into contracts with the state. I know you're kind of waiting and watching. Do you have any concerns? Do you have a time frame by which we'd have to make decisions about programs? I mean, it may be that it will get the contracts in a month and a half. And so it doesn't make sense to like stop programs, lay people off. Do you have a time frame by which you would start to get worried about sustainability?
Yeah, unfunded programs. Yeah. Yes, but I don't have I'm ever the optimist. I am hoping that by 5 o'clock tomorrow, or maybe even somebody will work on the weekend and make sure that those notices of award get to the states, because it's not just Washington, it's all the states. I did talk with somebody in
It's
Arizona.
nationwide. It's not
Do you
just
want to come up?
Washington State. Okay.
Oh, yeah. Oh, yeah.
Just to add, I'm a realist, got the optimist.
You gotta have both.
Optimist and realist.
You gotta
Finance.
have both people
Yeah.
together. That makes a
Yes.
good team.
So, what Dr. Thompson's referring to is, yes, there's some particular funding streams that we do not have the notice of award that from DOH to then go into our contract. However, the projects or the programs that are impacted on that have other funding streams, such as the FPHS. So we'll utilize those dollars in the interim while we're waiting on the other contracts. So there's no immediate concern, but certainly if it delays for a significant period of time.
So at least for the second half of the year, we should be okay. But then with the 26 budget, that if there's major issues,
Yeah.
we'll have to address that.
And we're expecting them, they have said July 1st or very close to that. So we'll just use the other funding streams.
I
that we
just
have
get
to
scared because there's
support.
been a lot of contracts at the federal level that have not come through or have been rescinded. So so it sounds like it's just a delay, but not a freezing of these dollars. Okay.
And that's what they're hoping.
Okay.
Okay, so the next one is really exciting. I don't know if anybody noticed as they drove up to the building today that there's parts of our building that look spanking new. It's really exciting. And so this is a graphic of where we are right now. The yellow shows how much of the building had been power washed as of Monday. I know that they've been continuing to power wash the building, and so that yellow line has moved. Then they do the brick demo, and that means that they're going in where there's a place where the mortar has been degrading. They're going in, chipping that out, getting to the point where the mortar is solid, and then they're replacing the mortar so that all of our bricks will be secure. And so that's very exciting. And then you can see that the caulking is the blue, and that takes a lot of work. Then total repair is the green. And so the inside, so the way they're doing it, there's bricks on the inside on the roof. And so that green is the inside of the roof. It's not the outside of the building. And then the last step is going to be to weather treat the building. And we're hoping that that will give this building many, many more years of life to serve the community with their health. So, any questions? Okay, so now
We
we're
were hearing the pounding just a few
Yes.
minutes ago.
yes.
So we know they're doing something out there.
Yeah.
Well-
And again, just to remind everybody, we did have bricks that were starting to be at risk of falling off the building. And so this conversation about doing some brick maintenance to our building has been ongoing, and it's time. And so I'm really, really excited that it's getting done. Yeah.
Great news. Thanks.
Yeah. Okay, treatment services. And I start, so again, we were talking about the surplus that treatment services currently has up to through May. So this doesn't include June, it's through May, and it's $302,784. Okay. Another thing that we're doing, and I shouldn't say we, I think it's mainly Diana Materney, Paula, they are working to renegotiate our insurance contracts. And so that's exciting. And then we also are newly with Cigna and Aetna. So we added those two insurance companies to our insurance profile. So that's very exciting. And with that, I'm going to turn this over to Adam.
So this is the legend that should be on the back of the treatment services numbers, and each line will essentially, as soon as you turn it over, correlate with what's on the front for each number. So it's just providing the definition for each one. In May, we basically were able to take on a lot more people, so we didn't have anybody having to wait from the day they came in until the day they were admitted. So it drove down the referral to admit days. And we turned away 12 people, unfortunately, but 8 of those people also returned. We discharged 39, and so overall we served 982 unique individuals just in OTP. But in courtesy dosing, it's staying roughly 60 per month, so 57. Lots of methadone, lots of buprenorphine still going out. Same as every month. Have any questions on the legend or numbers from in May?
I have a question, just to clarify. So unique dosing or unique OTP patients served.
Mm-hmm.
So in May, 982. So are those unique from April, 991? Or are those unique to May, some of which are the same as April?
Yep. It's
Okay.
unique
That's
only
what I thought.
in
I
that
just wanted
month.
to make sure that we weren't growing by.
Yeah. And the 2025 is that total is unique for all of this year. 1,123 so far this year. Any other ones?
No, I think the only comment is it seems like we've been in April and May, whatever changes you've been making to try and accommodate people coming in, for that initial intake, it seems you've cut in half the number of folks that had to be turned away. And so that's great. Do you have any sense, Misty, of are you making slight tweaks in schedules or accessibility of different of your staff when folks come in?
So really, it goes to speak to the staff that are seeing the patients. At any point that we've got individuals that are coming in, all of the team, we've got a Teams chat, and there's an exhaustive number of people that are on that chat, and everybody is really doing everything that they can to make sure that everyone that's coming in is able to be seen. And really, people are doing everything that they can to readjust their schedule, to work around whatever availability that they may have. If I've got a availability here, but I'm busy at this time, I can see someone here. Can you see someone at this time? And really just working together as a team to really bring in as many patients as they can. And that's really what accounts for that. So it's really the teamwork.
And remind me, for folks who are walk-ins, what are the hours that we actually truly see walk-ins? Because I know you, at the beginning and the end of the day, you have a lot of cleanup and paperwork. So, and then you have people that actually have appointments.
So the appointments are predominantly for individual counseling sessions.
Okay.
So then the majority of intakes happen at really 5:30, 6 o'clock in the morning. We do have others that can be scheduled and come in anywhere from 6:30 until roughly 10 a.m. But those do need to be scheduled at the later times just because of the counselors and the providers' schedules and making sure that we can align those out and line those out.
So the proposal that we were just discussing earlier, bringing on this whole new team allows you to then just see people all during those hours.
Correct.
Okay. Okay. Thank you.
We should have one more. So those appointments, we had 616 individual sessions mixed with the telehealth and the groups. The groups looks like it was a lot less, but it all just depends upon availability and what the individuals want to do per month. We did 45 assessments overall as far as the counselors, and the medical piece that matches up with it at the bottom, the intake physical was 47, which means that 2 of them did not do the complete assessment. And then we also did 1 jail assessment this past month in May, and still plenty of doses going to jail with 670 and still serving roughly 40 in May.
And you'll see that he did go back through and pull the numbers for the jail assessments, as that wasn't part of the report that we had previously had completed.
Yeah, so all the previous months are filled back in with a 2025 total.
Thank you for doing that. Appreciate it. It's interesting information and it's really easy to read. So nice job.
Okay, so if there's no more questions, we'll pass it off to Kim.
Thank you. Good afternoon. I'm just going to cover the May financials. A couple quick updates is the state auditors have begun their 2024 audits and they're in the planning stage. They're just wrapping that up. So there will be an audit exit conference documentation that will be sent to all of the board members as soon as they have identified all their planning and what they're going to cover. So that will be sent via Ann or Madison will come to everyone. That will outline what the audit's about. And then, of course, at the end of the audit, there will be an audit exit conference that will be scheduled as a Teams meeting. So we'll have board members participate as they're able without a quorum. And then the other thing that's happening is, of course, 2026 budget development will begin in July. So we're working in finance to put together the materials, the templates, and the software for everyone to begin their development. We'll be working hard on that July and August. And then, of course, bringing our first version or the first draft, if you will, in September's board meeting. So those are kind of finance activities at the moment. As far as the May financial reports, overall, we have a fund balance decrease of 497,000, not to be unexpected. The primary reason is that under the funding, the federal indirect grant and the state grant, we have not done the billing for those. So a lot of those expenditures are reimbursement based, and so we do have to use our unassigned reserves to cover those costs until we get reimbursed. And so not a surprise, it just happens to be the point in time of where we're at for May. Otherwise, it's a pretty routine month. And then as far as the reserves, we have different categories. The unassigned, we have a target of 20% of our budget. And so we're hitting 24% with the 13 million. Of course, we have the board emergency of 1.5. And then our assigned reserves, you'll see equal the 4,037,000. So after today's assignment for treatment services expansion, then I will be shifting the 850 from the unassigned to the assigned, and you'll see that reflected. It'll stay at the 850 until the annual update. So I won't be updating that every month. And unless there's any questions, that's just my short and sweet report. Thank you.
Thank you, Kim. Dr. V.
So good afternoon, everyone. I have a number of things, but they're mainly quick updates and a couple of things that I probably will drop off as we go into the summer. because summer technically is here as of a few days ago. So a couple of things that you may not have heard a lot about in the recent months, but that we need to update you, like animal bites and some update on COVID, which is mainly for your information and just in the event that anybody has any illness and they don't know what it is, because it's presenting in a variety of ways. So the first thing we're going to do is pertussis, and actually that number of 554 in Spokane just went up when we got the final report last night to about another 10 or so. But the reason why I bring this here is because we're starting to see the wax and wane as things start to tail off a little bit. So I probably won't be updating on this as we go forward unless we start to see more cases, because we started to see the transmission shift more to quote unquote home, meaning the community, because schools are out, et cetera, et cetera. And most of the cases that we hear about are either because of gatherings and or family activities, which is what you will expect at this point in time. So unless there are any significant changes, we'll keep tracking this. We will keep tracking this internally, but probably won't update on it unless there's any reason for it. So with that, I'm going to talk a little bit about animal bites. It's summer, weather is good, we're out there, and so are, dogs, cats, and other creatures. And one of the things I want to talk about is I'm going to focus on dogs, but there's nothing against dogs. Happens with cats too, but dogs are more common than cats. Almost half of all homes in the U.S. have at least one dog. I know some that have 3, 4. Like my daughter, she's got 4 dogs. Can't believe that, but. We do see about 4.5 million dog bites reported in the U.S. Every year. And the first thing that people wonder is why the dog bit me. And the second question I'm going to ask is, do I get rabies? Which is a question everybody typically asks. And dogs bite for a number of reasons. It could be protection. It could be they feel threatened. It could be playful. When you ask 1,000 dogs, you get 1,000 different answers. But according to the American Veterinary Association, these are the typical causes for dog bites. Remember, dogs are animals, and if they feel threatened, they will protect themselves, which they do. Now, typically when there's a dog bite that is significant, the first question people ask, oh, am I going to get rabies? And so I wanted to give you a couple of thoughts on rabies, just to get it off everybody's mind for the most part. As we all know, is a central nervous system disease caused by a virus that can actually be lethal if untreated. So it is something that we need to think about. But don't blame dogs because technically all mammals can actually have disease. So it's not just dogs. And the good news in the US since 2007, we do have declared basically that we're free of canine rabies because of all the vaccines that dogs, cats, and other pets go through. And we can add, cats and ferrets and all the animals who get vaccinated. The reason why I bring that up is because people do panic a little bit. And I know because we get the calls most of the time, which is fine. But rabies wouldn't be at the top of my list of concerns right now if I'm talking about a dog. Now, we do know that other animals can be carriers in other parts of the country and also here, like skunks and foxes and raccoons. In the U.S. and Washington State, bats are still the number one carrier that we know of. So that's why in the spring, when everybody's going to go and open their cabin, I don't have a cabin, so I don't have to worry about that. But people that don't, if you see a bat flying around, just let it be and don't worry about it. Now, I do want to say, if you look at the last point down there, that in the last 30 years or so, we have seen a variety of animals that have been infected, from horses to llamas to other creatures. So just to be mindful of. So what happens if you encounter a dog and it bites you? Well, first thing is call, and you can call one of those 2 numbers to let us know because we can provide you guys guidance. The post-exposure protocol involves a 4-dose vaccine, which is quite expensive, $3,000 to $7,000, give or take. And the reason why I bring that up is because we're getting, and I'm hearing a lot from our providers, that patients are calling them, I was bitten by a dog, I need to get the vaccine. And yes, please call your provider. Please go to your provider as directed. But I will probably worry more about wound care and infection and or other complications than rabies. And the reason why I say that is this is not as common, it's very expensive, not widely available. So if we use the supplies for cases with extremely low risk, we're burning out the stock that we have. So I just wanted to mention that. You will see, hopefully in the newspaper in the next few weeks, two of our team members just wrote a really good op-ed that we're keeping our fingers crossed that gets published for the community with some of the same bullet points. Okay, so with that, I'm going to move to, I know you thought you will never hear about COVID again, and I thought I will never talk about it again, but I just want to give you a heads up. In case you watch the news, you're going to hear about LP81, MB81, and Nimbus, which is a great name. Anyway, so what has happened in the recent past, particularly this LP, you're supposed to say LP.8.1, but I'm not going to LP81, has increased very, very, very quickly. And right behind it, topping the third of cases too, is its relative, the NB181, which is a so-called Nimbus. And the reason why I bring that up is the following. So we have a lot of symptoms that can be associated with this, something that is very common right now, and I've heard a couple of people sniffling. We'll have, not all of us, but many people have allergies. And it can present, I'm not looking at you, and it can present, I gotta look for Madison, and can present as an allergy type symptoms. It can also come up as a flu-like. It could be a sore throat. It could be GI symptoms. It could be almost anything. So the moral of the story is if you don't assume that it's allergies, you don't have allergies, don't assume that it was a virus, a GI virus. If it isn't, when in question, just get tested so you know, right? Now, one particular characteristic of the Nimbus, and as you read, they will tell you it's called Nimbus because somebody said it has an N and a B, so let's find a name that rhymes with that. So Nimbus has N and B. Has a very significant symptom, which is what they're calling a razor blade throat or razor throat, because it's so, that's a quote from a patient, is so dry and painful that you can't even swallow liquid sometimes. I bring that up because there are a lot of other reasons for sore throats. Viruses are number one. There's a whole bunch of them, but you can have a strep throat, which can be treated differently with antibiotics and has its own set of complications. So again, if you get like a real sore throat, don't assume it's a rhinovirus, don't assume it's a strep throat. It could be this, get tested, and that way you will know. With that, I'm going to move on to the measles, which is still making the rounds around the country. If you remember, last time we were here, we had 31 jurisdictions, now there's 36. We're seeing the biggest number on the 5 to 19 years of age. That's become the predominant population. Lots of theories behind that with vaccination rates, et cetera, et cetera, et cetera, et cetera. But basically, this is the group that we're seeing the most significant number of cases. And just so we'll know, in the state of Washington, we've had 3 different counties on the west side, none of them here, pretty much associated with travel. A lot of the cases we're seeing around the country are associated with travel also. We continue to be on task. As you can tell, bless you, by the numbers up there, or by the colors up there, we're not one of those areas with higher density, and we have not, I'm not going to say get tested, and we have not, you have a doctor next to you, she's probably going to say that, and we have not had, quote unquote, an outbreak, because an outbreak requires 3 cases in the same jurisdiction. So my favorite part, which is the community collaborations, on June the 10th, had the opportunity to present the Spokane City Council Chambers on behalf of Gabriel's Challenge, if you have heard about Gabriel's Challenge. And the good news, the great thing is we're able to present, like, what is the SRHD doing within the context of this crisis. And it's a great opportunity because a lot of people haven't connected all the dots of everything we do. So I want to say thank you to Josh from Community Health and Kelly, who helped me put this together. It was very well received, and people, some people were surprised about all the things we do, and some people were like, oh, I knew that, but I didn't know it was you. So Now they know. Now, last week we had a great event for our Medical Reserve Corps. As you know, we do have an active Medical Reserve Corps. That's part of the first annual report we have produced up in 2024. This is the ongoing in 2025. These are some of our Medical Reserve Corps, and they continue to be extremely active in the community. Example, doing a lot of naloxone training. Also suicide prevention and reporting. And we just started in the last couple of weeks a partnership with the YMCA to train all of their staff, and also at some point have dispensers for naloxone at all of the Ys, which are great points of access for people. So these are some of the members of the team that were there. The young lady back here is Jennifer Walls, she's a coordinator for our Medical Reserve Corps. So if you see one of those folks, say thank you. And I'm almost done. I'm going really fast. So the WAMOA, you guys know what WAMOA is? Come on. It's the Washington Association of Maintenance and Operations Administrators. So our team was actually invited to participate in this meeting for the first time, which is great because this includes a lot of partners in education. So we had members from the environmental public health as well from EPI, providing a number of lectures in this day event that just happened. So we're very happy that we were invited, and we hope we get invited back because it's another forum for us to provide information and access to knowledge and context. Pools and water resources, most of people are opening their pools or building a pool or digging a hole in the backyard, depending on what stage you are in. And I wanted to give you a little bit of a high level of what is it that our team does with all these pools. Because people think about pools, but they don't think about spas or spray pools or ninja crosses or aqua zip and ropes and et cetera, all these new things. And if you just look at the numbers, these folks are really, really busy. And it's not just in the summer because there's a lot of things that happen year round. Because remember, they're indoor facilities too. And many of these indoor facilities are part of those inspections. And they do a great job of not only helping particularly accommodate all of these new types of water-based motifs. I don't know if you've seen the Ninja Cross. I've seen it, I've never done it. It's like obstacles. It looks like one of those, shows. But our team is really, really active. And I just wanted to put that out there because it's hundreds and hundreds of inspections, hundreds and hundreds and hundreds and hundreds and hundreds of hours for a lot of facilities that people may not even know that we actually inspect, like some of the spas, et cetera. Yes.
Dr. Velazquez, I was wondering, I would like to make a comment. And so anyone that has and is responsible for a public pool, if they do any upgrades to it, even if it's painting the pool, they need to contact us so we can come and inspect what they're planning to do and approve it. Because, for example, if they use the wrong color of paint in the pool, they're going to have to repaint it. And so just for the community's benefit, if you're responsible for a public pool, make sure and contact us before you do any updates to your pool.
Thank you. Good comment. And that's the way to contact us is down there. And repainting or resurfacing your pool is something that does require for us to take a look. So with that, I'm going to stop here and see if there are any questions. Thank you. Melissa, I think you're next.
I think we have time. Thank you for being patient, and we do not want to reschedule you again. We're eager to hear what you have to say.
Back again.
Welcome, Melissa.
Thank you. Okay, so this is my first time presenting here. Please tell me is there a special place I need to look? Is there any? Okay, and the buttons, these are the buttons. We don't use the clicker. You use the buttons. Okay.
This is actually easier to forward it.
Okay.
Forward and back.
Thank you.
Welcome.
All right. For those of you that don't know me, I am Melissa McDaniel. I'm the Division Director of Community Health here. And these 2024 accomplishments that I'm going to share, this stems from one of our division meetings that we had at the beginning of the year in February. And we try to get together in the beginning of the year to really celebrate what we did throughout the previous year. So, are we ready? So in our Women, Infant, and Children Nutrition Program, WIC, we served 9,122 individuals with over 32 different languages. Something they're super proud of, as they should be, they received a glowing review on their DOH monitor, which they're saying they were called the gold standard program, and they're actually sought out statewide to provide support and feedback. They created the breastfeeding expert position and put plans in place to start a breastfeeding walk-in clinic in 2025, which it's actually working right now. And we've seen so much growth that they've had to expand staffing for that in 2025 already. The way that was described to me is that's kind of like your breastfeeding bestie. So anytime, 24/7, they've got a phone. If you've got a question, you can give them a call, which is pretty cool. I won't go through everything just for the sake of time. You can read the rest of this, but there's some pretty cool things they've done with universities as well. Nurse Family Partnership served 179 clients with 66 new clients and 38 client graduations. They started this super cool baby book club to increase literacy education, which has been really successful. They received funding for the Blue Bands initiative through DOH, which they've also seen pretty successful. I don't have data on that right now. And they became the first HOPE certified program at SRHD with TA support from the Healthy Living team. And earlier today, I got to sit in, so it's not on my slide, but they received their participation or their participant feedback survey results. They had a 97.3% response rate and a 92.31% satisfaction rate. They exceeded the highest score benchmark, and it falls as a world-class program, which is super cool. So, and I will share that with Dr. Thompson. I may even have them come present to ELT, and if we want to bring it here, it was amazing to see. They work with the data center on this. HIV case management, 557 clients served in 2024 with a significant increase, 11.6%. 99% of clients are prescribed treatment, and 90.7% of clients were virally suppressed at their last lab. Peer support, about 5% of our clients worked with a peer. Really cool thing that's come to fruition. As of the last couple of weeks, we received funding for a full-time peer position, which we're working on filling. Housing, 21 clients assisted with moving into housing for homelessness, prevented 16 households from eviction, and assisted 130 households with housing support. I'm trying to go fast. I think I need to slow down. Healthy living. They started their walk audit pilot program. They conducted 5 walk audits with 50 community members. They started a healthy aging community of practice with 12 LHJs and DOH participating. I'm excited to see how that comes to fruition in 2025. 6,000 kits of Narcan were distributed, and approximately 5,000 healthcare professionals were reached with the brief, which is a news blast with emerging public health information. They also distributed almost 7,000 safe sleep and firearm safety education materials, and 1,000 prenatal partners were impacted by early relational health programs, and that's our HOPE program, which I think some of you are familiar with. Healthy Families, our ESIT program, as well as our Access to Baby and Child Dentistry program. So they served 3,161 children, 91.86% of the children enrolled in early intervention services receive those services in natural environments. So for those of you that don't know, the goal of ESIT is to serve children and families in their homes, in their daycares, and that's what they consider natural environment. And they also held 4 county interagency coordinating council meetings, which is something that has started to resume after COVID. During COVID, there was a pause there, and it's really cool to see that we now have parents who are leading this versus our staff leading it. Access to baby and child dentistry, super busy last year. Attended 20 probably plus outreach events. They provided phase 1 training, phase 2 training, and also were able to provide phase 1 training to the EWU dental students. And our children, youth with special healthcare needs. This is really fun. She started, supported the startup of the Spokane Autism Collaborative. And they're currently working on a Marshall E's autism educational project that's coming to life right now. They're working with comms. Supported the planning and day of efforts of the Family Support Conference, which they're currently working on 2025s right now. And 195 families were connected to resources. And then for the Work First contract, there were 52 Work First evaluations completed in 2024. Do you have any questions? I got through it.
No, those are some outstanding numbers. And
Yeah.
we have nationally and world recognized programs.
It's
here.
amazing. They're doing
So
amazing work.
congratulations
Yeah,
to all
thank
your
you.
teams.
Yeah.
And keep up the great work.
Awesome.
Thanks
Thank
for the
you.
report.
Yeah. Is there anything I need to turn off or do? Just walk away. Okay, I got it.
Well, we'll have a little time just for a board member check-in. And I don't think we have any other citizens signed up for input. So, board member Duranoa.
I'm good to go.
Okay, Dr. Blakowski-May.
I'm good to go. Thank you.
All right, I'm going to go to virtually Commissioner Cuny. Any updates or announcements?
Yep, no, I'm good, thank you.
Okay, board member Keenholz.
Nothing to report.
Okay. Well, I think I'm just glad we ended pretty much close to our goal today. So good job to executive committee and everyone for finally, I think getting our agenda the right amount for today. And we even had a lot of discussion on our action items. So excellent. Well, I guess the next board meeting will be July 31st. And then we skip the month of August. So if that's all, then I'll adjourn the meeting. Thank you. We'll see you next month.